Right. Welcome, everybody. I'm looking at our participant list. I see lots of familiar faces and then just a couple of new folk. Some of what you'll hear today for those who are return attendees, you'll have heard before, but we do have some new exciting things for our data users group today. So without any further ado, why don't we start? My name is Kenley Money. Good afternoon, and welcome to the April 2024 Arkansas APCD Data Users Group. This is our 19th session. We've been doing that many. If you do the math, 4 a year, 19th. It's been a great, great ride. For those of you who are new, the Arkansas APCD is part of the Arkansas Healthcare Transparency Initiative, or ACHI. That's the acronym, and it's administered by the Arkansas Center for Health Improvement, ACHI for short, ACHI. And it's comprised, the APCD is comprised of private and public carrier data, payer data, medical claims, pharmacy claims, dental claims, as well as enrollment and provider data. Additionally, that's the APCD, but as part of that, under the umbrella of the HTI, the Transparency Initiative, we include key data sets from the Arkansas Department of Health, including Arkansas Vital Statistics, birth certificates, death certificates, the Arkansas Hospital inpatient discharge data, and emergency department data for those who are self-pay or uninsured. And one of our favorite data sources is the Arkansas Cancer Registry, plus some medical marijuana cardholder data, which is a topic for today's agenda. We also have some Arkansas workers' compensation data, and we hope that you'll find today's session very helpful. We have some process discussion, some analytics methodology discussion, and some new data asset discussion. Some housekeeping before we move forward. Feel free to type your questions in the chat at any time. We'll get them as we can, and our project manager, Cecilia Kirst, is at the ready to alert me to that. Sometimes I miss it. And at the end of today's session, there will be a link to our service desk portal where you can submit questions. And we encourage you to take the opportunity to reach out to our team, ask for some one-on-one help. The APCD and its sister data sets, the health department data, are very complicated. And sometimes a little help would be necessary to further your project. So, and also I have to say our next data users group is in July 24th. So, all right, let me move forward. Hello. There we go. The agenda today, welcome, we've had that. Our featured topic is using clinical classification software, refine CCS-R to support APCD analyses. We're going to talk about some refreshed medical marijuana cardholder data, long time overdue, a new data asset offering called MEST, Member Enrollment Selection Table, and then, as always, the latest release information and some data tips that we've used in the recent past or are new. Right? Our presenters are me, Kenley Money, the Director of Information Systems Architecture, or the APCD Director at ACHI, and Dr. Nicole Stanley, the Interim Director of Analytics at ACHI. All right, without further ado, let's get to our featured speaker, which would be Dr. Stanley, who is arguably the first APCD super user. And Nicole, I'm going to turn it over to you.
Awesome. Thank you, Kenley. As Kenley said, my name is Nicole Stanley. I'm currently the Interim Director of Analytics, and I've been here at ACHI for almost 7 years. And yes, I got to start playing with the APCD when it was still young. Okay, so I know that the agenda originally that went out was focused on diagnosis codes using the clinical classification software refined with diagnosis codes in particular, but it's very close to procedure codes. You would essentially use them in the same manner. So I've gone ahead and thrown that in there too. Oh, can you go to the next slide?
You bet. You just tell me. There we go.
Okay, so the clinical classification software revised, which I will now refer to as the CCS-R, was developed by the Agency for Healthcare Research and Quality, which we typically call AHRQ, as part of the Healthcare Cost and Utilization Project, or HCUP, to help inform decision-making processes. It categorizes the ICD-10 diagnosis codes and procedure codes separately. The categorization of these codes started during the implementation, or it goes back to the implementation of the ICD-10 codes. Typically, which started in October 2015, it's typically updated at least each September. I think there's occasional updates in between, such as when COVID, the diagnosis code for COVID came into existence, and they created a CCS-R category for that. Next slide. So the CCS-R procedure code groups over the 80,000 ICD-10 procedure codes that exist into 320 clinical categories, which covers 31 clinical domains. And the nice thing about using the procedure codes is that there is only, for each for each procedure code, it is only assigned to one CCS-R category. Examples of categories include imaging, pregnancy-related procedures, skin and breast procedures, and of course, many, many more. Next slide, please. Now, the diagnosis code groups have the over 70,000 ICD-10 diagnosis codes. They're grouped into 530 clinical categories, which cover the 22 body systems. One of the nice things about the categories for the diagnosis codes is that the first 3 characters of the code basically has the body system. So if you're interested in eye-related codes, the first 3 characters of the eye categories are literally EYE. For instance, the mental and behavioral health disorders start with MBD. So that is a nice little easy way to look at the categories. Now these categories cover, the one drawback to the ICD-10 diagnosis codes is that they can be assigned to more than one CCS-R category. Some examples of the categories include abdominal hernia, diabetes mellitus type 2, diabetes mellitus with complications, and diabetes mellitus without complications. And you'll see in our example that diabetes is one of those ICD-10 codes that can be assigned to more than one category. And it makes sense when you're looking at it. Next slide. The way ACHI applies the use of the CCS-R is we sometimes use it to identify the codes that will cover our topic of interest and use those codes to extract our claims. So if we were interested in imaging claims, we would look at the imaging ICD-10 procedure codes and use those as a group to extract our claims. If we're interested in type 2 diabetes, we would use the diagnosis codes assigned to the type 2 diabetes category to extract our claims and identify a population. We also use them to categorize utilization and costs. So in that scenario, perhaps you're interested in the cost of diabetes with or without complications. Let's go to the next slide. So diabetes is a really good example of the 2-category problem. So you can see here we have E10.9. Of course, in all of our data, the period is compressed out of our codes. That represents type 1 diabetes mellitus without complications. It is assigned to either diabetes mellitus without complication or diabetes mellitus type 2, or type 1, sorry. Now, depending on the study question, you can use the default assignments to select one grouping. Now, the default assignments, you see we have inpatient and outpatient. These are really for if you're interested in costs specific for inpatient claims or outpatient claims. Now, if you think about it, diabetes mellitus without complications or with complication is really something that you would be interested in with costs. You wouldn't necessarily be interested in the costs for type 1 diabetes and the cost for type 2 diabetes. You might be, but type 1 is a very small population versus the type 2 population, right? So, for example, we would typically use the type 1 assignment END004 or the type 2 assignment END006, I think, to identify individuals with diabetes. Whereas we would use the mellitus or diabetes mellitus with or without complications to divide costs. And that makes sense too, because diabetes without complications is of course going to be cheaper, more affordable than if we have diabetes with complications. Next slide, please. So to use the default, to choose which default to use, let me first say that if your inpatient default CCS-R category is Y, that obviously means the category is the default, and that's the same for the outpatient, of course. If the category is, or I'm sorry, if that value is N, then it is not the default, and there is most likely a field that is, or a category that is the default. And then finally, if there's an X, now it's not necessarily that that code should not be a primary diagnosis. There are a few other reasons, default reasons, that they choose one over the other or not at all. You can see that in a new field, which I don't have here, which is the rationale for the default assignment. But in this case, B6013, the keratoconjunctivitis due to acantha amoeba, is not, should not be a primary diagnosis for either inpatient or outpatient claims. However, maybe you're interested in parasitic categories, in which case you don't need to worry about the defaults. You can just use this category and the codes associated with that category to identify people. Next slide. So how to use these categories with the Arkansas APCD. At the end of this, my bit of presentation, I have added links for background information and links for where to find these particular tables online. So if you were interested in procedure codes, you would use the APCD fields MC058 through MC058L. And you would link those in the CSV file to just the ICD-10 PCS field. And again, any periods, which I'm sorry, I don't remember if the procedure codes also have periods, but they're compressed out. With the ICD-10 diagnosis codes, those fields are MC041 through MC053, where MC041 is the primary diagnosis. The others are all secondary diagnoses. There is also an MC039, which is admitting diagnosis, and MC040, which would be accident codes. just for your awareness, typically we use the primary diagnosis. That's the diagnosis that's assigned after all of the tests and whatnot. And that file, you can see here, you actually have 4 spreadsheets in that particular reference file, and you would use the DX to CCS-R mapping, and the field would be the ICD-10 CM code field. Next slide, please. So some considerations when you are deciding whether or not to use or how to use the CCS-R categories. One thing, if you're identifying a study population, you really need to review your codes in the categories with a subject matter expert. For instance, what if you were interested in the incidence of a particular diagnosis or category? You may not want to find claims in 1 year that are sequelae claims. You may be needing to look for, well, you would be looking for the first case of the first claim with that diagnosis. A sequelae code means that it's a follow-up to the diagnosis. Maybe you're interested in mental health disorders, but maybe what you're not interested in is psychosis due to a stimulant. Those can be wrapped into the mental health disorder codes as well. Are you okay with a claim being an unacceptable primary diagnosis? Does that matter? Typically, if we're interested in identifying people, it doesn't really matter. The other thing for consideration is, are you interested in mutually exclusive costs? Now, that there is some trickiness with that. It is designed to assign to either inpatient or outpatient claims. However, maybe you're interested in all the costs of a particular CCS-R category. In that case, that's not a big deal. You use just that particular CCS-R category. But if you were interested in the costs for all the categories, just be aware that not every single one is mutually exclusive. So obviously don't try to add the costs across all the categories. Next slide. And here is the helpful links that I mentioned. You have background information for the CCS-R for each of the code types. I've included a link to those background informations and a link to the zip files with those spreadsheets that you would need. We can either save questions for the end of the DUG, or I can answer questions now.
Does anybody have any questions? If not, I do. Well, I'll start. Perhaps I'll be the primer. So Nicole, I'm going to go back a couple of slides. This slide and this slide, when we have a diagnosis or procedure code with 2 of these category codes, I understand the value of selecting the one that is most specific to your study question.
Mm-hmm.
But overall, is there a general way to select which one you use outside of the default? Do some of these codes have X's?
So, I have not counted how many codes actually cannot be assigned because that you can't choose from, that are in 2 categories because perhaps they have X's in both.
Mm-hmm.
So I don't know the extent. I don't think it's small. I'm sorry. I don't think it's a large number that cannot be assigned. It's really going to be up to the researcher. I think if you want to show costs for all of your claims, then I think the best method would be to not use the default. If you don't care if it's inpatient or outpatient, then don't use the defaults. Go ahead and assign all the categories. Mm-hmm. Even though we have diabetes mellitus without complication, which has type 1 and type 2, that's information costs
Mhm.
related to that particular category could be as meaningful as the costs just related to type 1. So, yeah, does that help?
And that does. I could see where this type of almost an artesian type nuance would be confusing. So I wanted to put a pin in it just a little bit. Thank you very much. Anybody else have a question? No?
Sarah,
Well, go ahead.
so one of our other one of our team members who uses the CCS-R category a lot, I believe, is on. Sarah, are you there?
Thought I saw her.
I'm here.
Did I leave anything off that you think might be beneficial?
I was just going to say to let everyone know that this the spreadsheets that are available at the links that were up there, those are free to download. And so anyone who's using the APCD can get access to those, and it's just an easy way to categorize your claims. If that's something that you need, it's there. Also, if you download it and then you work with it, and then like 2 years later, whatever, you're working with it again, and you're finding that you're getting a lot of ICD-10 codes that aren't being assigned to a CCS-R, make sure that you're working with the most recent version, because they do update it regularly. And so any new ICD-10 codes that come out, which they do all the time, you're going to want to make sure that you have the most recent version for those.
And to be clear, when Sarah said they're for free and you can get them with the data, you would need to reach out. You would need to go online and get them yourselves.
Yes, yeah, you
They
need to
would
go
not
online to the link that we showed there, but you don't need to pay to download the files or anything.
I forgot to mention in the beginning, in the intro, that these presentations and this recording will be available to everybody, and everyone participating today will get an email with links so that you can reference this data and have these links at hand. Well, great. Thank you very much, Nicole and Sarah, a special guest. Let me move forward here. Okay. So the next topic at hand is refreshed Arkansas medical marijuana cardholder data. We have, for those of you who have utilized our data, when if you had a subscription, you probably had access to the medical marijuana cardholder data. Some folks have purchased it with data requests outside of a subscription, whatever. It was first added to the Transparency Initiative as part of the APCD back in 2019-ish. And we had data from August 2018 through September 2020. And then we stopped refreshing the data. And to be clear, these data represent individual Arkansas residents who had a medical marijuana card. So it's enrollment data. It's not point of sale data. It doesn't have anything to do with purchases or how many grams were purchased or distributed. It has nothing to do with that. It's just a record that represents that an individual had a card at this time. But the original source of the data stopped providing the data, hence the gap. But now new refreshed cardholder data is available, and we're about to release it. It contains data from August 2018 through September 22. The original data is included in this file. And I say that for those who have been using the original data. So it's the original and then new data. And subsequent data, we do receive it regularly now, and these data will be released systematically thereafter. I'm not sure of the release timing, probably annually, but that means the next release is going to have data from October 22 through probably February of 24. Not sure. 2 big chunks, and then we're going to have a regular cadence. So the original, let's talk about some differences here. The original data had 100,000 unique cardholders, and the new data, the data we're going to release through September 22 in the next month or so, it has 255,000 unique cardholders, but that includes the original ones. So, and you see the dates, we talked about the dates a moment. In the original data, there was a very short or narrow file. There was no explicit enrollment date or expiration date. There was just a date of the month that the cardholder data came to us. So you had to really work through all the data to figure out when a person first got a card and stopped having a card. And the new data has explicit enrollment dates and expiration dates. The old data will not be updated. If you have it in a subscription, you will never get the old data again. You'll get the new data. And as we said a moment ago, it'll be updated periodically. And the original data isn't available except that which is in the new file. There's no change in price or in the way to request the data. So all of this is very, very good news. And I thought I would, for those of you who are data people who like to look at bits and bytes, not literally, I'm going to unshare this. Let's see, stop share. And then I'm going to reshare. And I'm going to go over here. Okay. Are you seeing data on your screens? What are you seeing?
We see what looks like to be the APCD data
Is it
file.
The what? I'm sorry?
It's like a data file.
Yeah. Okay. On my screen, it didn't change color, so I wasn't certain if it actually shared. So this is the data that is in the new medical marijuana card holder file. And it has the unique ID, which is the hash ID. And it has, it does have date of birth, though I represented just the birth year here. If you need date of birth, in the data request process, you'll have to justify the need for a date of birth. And it has the age of enrollment, which we can calculate, gender and zip code. Now this represents, you see 3-digit and 5-digit zips. The 3-digit zips are those from the original data because it did not come with a 5-digit zip. The 5-digit zip is in the new data. However, a regular data request will only give you access to a 3-digit zip without justification. Then here's the enrollment date and the expiration date from the new source. And we applied county FIPS, and these are source indicators. This is simply a row ID, and this is the day we built the file. So this is what it's going to look like, give or take, if you get permission to have full zip and full date of birth. In the old days, it was you would have for like this one here, you'd have a row for every single month in this enrollment period. So the fewer rows, yay. But this is what it looks like for you people who enjoy looking at data files. I thought that would be helpful. I'm going to go. Does anybody have any questions? No? All right, so I have gone back to my deck. And let's go to our next topic. We have a new data asset that we have built largely through using the expertise of Dr. Stanley and her team. What you're seeing are some slides from our marketing material, but we'll go for it. So you might recall that last year, about this time, we put out a survey to all of our data users and asked for opinion and had a lot of questions. And the things that the pain that we heard the most was described in these 3 bullets: the identification of enrollment periods, breaks in coverage, and coverage transitions. We heard very clearly that data users spent most of their time working through the enrollment data just to get an understanding of when people were enrolled. Once they did that, they could go get the claims for their analytics with relative ease. We had back in the summer, late summer of 2023, we had a prototype, you might recall, it's up on a recording. And then that prototype morphed into what you see here, which is a more usable file. And we call it the member enrollment selection table, or MEST. And it's going to allow users to easily segment and identify qualified study populations by member enrollment coverage, activity by month, year. And it also has the payer type categorization as part of it. And this is a new field that we added to the APCD enrollment data about 4 months ago. At ME001_CAT, whatever, but it will, based using informed business rules, it will categorize an enrollment in some high level categories like commercial or Medicare Advantage or QHP or Medicaid, things like that. The rules for that payer type assignment are in the supporting documentation that will come with the acquisition of the MEST file. So how does it work? Oh, wait, I have someone in the chat here. Oh, yay, yay. That's right, Austin. Austin says yay. Oop. I'm sorry, I got ahead of myself. I was excited. So these 2 rows here represent, in a narrow way, what you see in the enrollment data today. This is the same individual, and they have a Medicare Advantage plan, and then a commercial plan. Again, those labels are assigned using the business rules. And the Medicare Advantage plan runs from this date to this date, and the commercial from this date to this date. So we have 2 records. What on earth do you do with that to figure out continuous coverage, overlapping coverage, etc.? So what MEST does is breaks it into these rows. So those 2 records turned into 6 records, and by year and month. And actually, I'm going to move to the next slide, and then we'll come back to this slide. So you see this enrollment string field here. Okay, this is how it works. This is the record you saw in the previous slide, and the enrollment string for this particular person. This example. This person had commercial coverage in 2022 for the months of March, April, May, June, and July. So you see the 1s here, and then the 0s represent that there was no coverage. This person had no coverage in 2022 for commercial. And we add a counter here to make it easier for the user. But that's how the enrollment string works, right? And there are rules. There's an asterisk here about some rules that how we calculated coverage, and if the coverage began the last half of the month, where to count it, et cetera, et cetera. All of that is in the supporting documentation. But using this, let's go back. So this particular example, this made-up person has 6 rows, and they had a Medicare Advantage plan that began in September of 2018 and went through the end of the year, and then ended in, what is that, May of 2019. So then at the same time, they had a commercial plan that began in July of 2018, and it continued. It never stopped through 2021. So you can see using the enrollment string that this person had continuous coverage and also overlapping coverage. And that is what that answers a couple of the questions that we intended this tool to do. And it also talks about transitions in coverage. This person didn't really transition from one to another, but you could get there if you had to. If one coverage ended 1 month and the second began and never, yeah. So this is the MEST file. It assigns an enrollment string of 1 row per member per year per payer type. And I thought I will, let me see. Oh, and once you have the members that you want in your study population, then you can take your member ID and your submitter, the SEID, and then you can mine the claims. Now that you have this right here, you can go get all the claims that you want. This example has medical and pharmacy. There we go. All right, so while we're here, let's stop sharing. And for those of you who like to actually look at data, it's not much different than the example, but All right. Okay, so you should see another data file, and here are the fields, just like the example in the slides. Your unique ID or hash ID, gender, all that. So this, any questions so far? No? Okay. Great. All right, let me go back. All right. Thank you. All right, so if you want to apply this table to research, it allows data users to determine easily and accurately when a member's enrollment begins and ends, what their payer type is, and it can help ensure that projects have the qualified members whose enrollment may span years, identify transitions, etc. So there are a couple of ways to get these data. The MEST file is available as a data set you can buy along with or acquire along with other files in a data request. Typically, data requesters purchase enrollment data, medical claims data, pharmacy data, and you could buy this one along with it. And or if you need to, or if you'd rather, you can engage the Arkansas APCD team to pull the data based on enrollment criteria using the continuous MEST file. And we would work with you. If you didn't want to man it, if you didn't want that, if you didn't want to get it, you didn't want to mess with it, then we could help you with that. So the next steps are, we are updating the website, the data request tool on the website to include this, and there'll be pricing. It'll be priced by year like the other data, like the enrollment data and the claims data. And then we'll make all of the documentation available. So look for an email very soon. This summer, this is coming out, and you will be able to try your luck with our member enrollment selection table, or MEST. Anybody have any questions? A quiet group. All right. Let's move on. We're closing to the end. Right now, the current APCD data available is through March of 23, though we do have data beyond that. It's just not the full set. We are beginning the next build, and the latest data, which will go through September 23, will be available probably in August. And you'll recall that our data is always staggered. We're about 6 months behind on a release to the data that we already received. And with each data release, there are release notes. All of this you're probably fairly familiar with in universe accounts, data dictionaries, and tip sheets. And the most important thing are your tip sheets, because things change all the time. And these just happen to be some of the tips that were used this last quarter that rose to the top. This one, the Cigna entity study ID issue, was resolved. So I wanted to bring this to your attention. And there are new HIOS ID variant codes. Let's see if I can actually get to that one. Come on. You gonna let me? Stand by, and let's hope the sharing actually works. Are you able to see the screen change here? Yes.
No, we are not able to.
You are not. Thank you very much. All right, stand by. Okay. Note to self: in a Zoom call, don't assume that what you click on will be shared. All right, you should be able to see it now. For those of you who do any work with qualified health plans or AR Home, what used to be the private option plans, one of the most important variables is your HIOS ID. That's in ME992. Plans that are not part of those programs do not have a HIOS ID. They should not. For example, the last 2 bytes of a a HIOS ID. If it's 32 or 36, that means that they support the Medicaid Healthcare Independence Act and thereafter. But the last 2 digits of a HIOS ID are called variants. And it's no longer just 00 to 06 and then 32 and 36. It has expanded. And so I recommend that if you are doing work with qualified health plans, that you click on this and look at the expansion and see the other values that are available now. If you profile them, they're not a lot that have variants not equal to 00 to 06 and 32, 36, but they're there and they are used. So I wanted to bring that to your attention. And you probably saw that in your February 2024 data tips email. If you do not get that email, please let me know. All right, I'm going to stop sharing and go back. Oops. Okay. All right. Well, that really is at the end. We're at 12:45. Does anybody have any final questions? Do you have any projects that are upcoming or have any data use questions that you would like to discuss today? No? Austin, surely you have a question.
No, not yet. I'm curious to get into the mess file though.
Yep. Okay.
Playing with it, so I'm sure I'll have questions then.
Yes, absolutely. If you have ideas for future data user group meetings, send them our way because we are here for you. We want to help make the use of this data easy and fast. So we want to, and if we can't address your question immediately, maybe it's a process improvement we can incorporate going forward. Send ideas too. All right. Our next meeting is July 24th, 2024. Sign up for our newsletter. And again, if you are not receiving the data tips email, please let us know because probably everyone on this call is. We try to sync up these lists, distribution lists, but we may miss somebody. Well, everybody, thank you very much. I'm going to give you back 14 minutes and I look forward to speaking with you. Oh, wait. Oh, yes. Speaking with you in July. Have a good day.